Yay, well, let's get going. Well, hello, everyone, and thanks for joining in on tonight's webinar, Health Risks of Extreme Heat and How to Build Resilience. I'm Susan Campbell, Co-State Coordinator with Colorado Citizens Climate Lobby, and I will serve as moderator for tonight's webinar. This event is co-hosted by Healthy Air and Water Colorado, also known as HAWK, and Colorado Citizens Climate Lobby. Citizens Climate is a national nonprofit, nonpartisan organization focused on advocating for climate change solutions in Congress and in communities here in Colorado and across the country. HAWK is also a nonprofit, nonpartisan organization elevating the voice of health professionals to raise awareness of the growing public health threats of climate change. We're pleased to be joined tonight by speakers from two other organizations taking on climate change, Nevada Clinicians for Climate Action and Montana Health Professionals for a Healthy Climate. Both of these organizations, along with HAWK, are state affiliates of the Medical Society Consortium on Climate and Health. We've packed a lot of information into tonight's webinar. Before proceeding, let me just mention that we will have a Q&A period at the end of the webinar. So please type your questions into the Q&A space, which you can pull up by clicking on the Q&A button on your toolbar. We'll answer as many questions as we can. Dr. Kate Jennings, who is the Education Committee Chair of HAWK, will be moderating the Q&A. So we'll begin tonight with an overview of how high heat impacts human health, including its effects on certain groups within the population. Our speaker will be Dr. Joanne Leovi, a family physician practicing in Las Vegas, Nevada. She is chair of Nevada Clinicians for Climate Action and a leader with Citizens Climate Lobby's National Health Action Team. Joanne, you have the floor.
Thank you so much, Susan, for that great introduction. And thanks to all the participants here for taking time out of your busy day, the end of a busy day, to listen to us. So I just want to get a thumbs up if you can see my slides okay and hear me okay. Awesome. So as Susan mentioned, I am a family doctor, and I'm going to talk a little bit about kind of from a community health perspective and a primary care perspective about extreme heat. One of my main qualifications for being on this talk is that I happen to live in Las Vegas, a really hot place. And when it's too hot to party in Vegas, we got a problem. So it's something that we've started to grapple with. So what you can see on the left is a picture of my city, Las Vegas, and you can see that it's in a deep bowl-shaped valley surrounded on all sides by hills. Las Vegas has the second fastest warming of any city in the country, just behind Reno, and one of the largest heat island effects in the country, and that has to do with the large amount of pavement and concrete that you can see all over through this picture. And so we really have to grapple with heat. But it's not just here. And one of the reasons that I want to come on this presentation is because heat is becoming a problem all over the country. And you can see from these maps on the right from the EPA that over the past 60 years, everywhere in the country has had an increase in the frequency of heat waves, how long they last, how intense they are, and the season where they're starting earlier in the spring and extending longer into the fall. This is especially important in places that might have moderate climates and where heat might be a thing that we're not really paying attention to. So it's problematic, but it also gives us an opportunity, I think, to start grappling around the country as we treat patients in our office. And heat is something now being experienced by everyone, as we know from this week's Midwest and East Coast heat wave. It's kind of a nonpartisan problem and something that everybody can really grapple with when we think about climate change. So Rob and Logan are going to talk a little bit later in detail about people at risk, but I want to just point out briefly that The risk of heat illness has to do with really two factors. One is individual vulnerability and differences between individuals. So we know people like the very young and the very elderly, low income folks who might have difficulty affording their air conditioning, people with chronic disease, and people on chronic medications are all at higher risk. Social isolation is a big risk. And not being acclimatized to heat is problematic, especially when we get a heat wave in places that aren't used to it. So, individual vulnerabilities are one issue. And the second is the amount of exposure. This is not so much an individual issue as a community, neighborhood, occupation issue. It affects groups of people. So this is three maps of the Las Vegas Valley, and I just think it's fascinating to look at the patterns. On the upper left, we have the heat vulnerability, and you can see because we're a big bowl-shaped valley that the central city and especially the east and northeast sides of the city have the highest heat as shown in those dark red and orange census tract areas. In the middle, we have a map by census tract of income with the lowest income being the deep brick red and orange colors and the higher incomes being the blue area. Also, we can see the low income areas are in the east and northeast side of the valley. And on the bottom right is a map of where heat deaths occurred last year in 2024. And isn't it fascinating that we see the same pattern? So the exposure that different members of our community have plays a big role in their risk of having heat illness. Last year in Southern Nevada, we had record-breaking heat, including about a 2-week stretch in July where we really had heat that even I have never seen after more than 20 years of living here. High temperatures over 110 to 115 for many days in a row. And we had a record 527 heat-related deaths. So our county coroner and our Southern Nevada Health District, the health department, have done a great job in investigating those deaths and trying to help us understand. And I thought it would be interesting for us just to take a minute to look and see who really dies of heat illness. So on the upper right, you see that bar graph. We think about elderly people as being at risk, but actually middle-aged people between 45 and 64 were the largest category of deaths. The first thing we think of when we think of somebody dying from heat is our homeless population, but actually more people were housed than unhoused who died from heat in Las Vegas last year. Co-occurring substance use is a huge problem. Over half of the heat-related deaths had substance use involved, and stimulants, especially methamphetamine, were huge. And interestingly, there are some differences by race and ethnicity. Uh, our Black and Hispanic population tend to live in those more heat vulnerable areas in the northeast and east sides of town and the central city. And in fact, the Black population had higher rates of death compared to the percentage of population. Non-Hispanic whites had slightly lower rates of death, but our large Hispanic population had a much lower rate of death compared to their percentage of the population. And so I think that's fascinating. And I just invite you to think a little bit about why that might be. Maybe we can talk about it during the question and answer period, or you can put your thoughts in the chat as we go along. In this, we see two graphs. On the left, heat-related deaths, and on the right, heat-related emergency room visits over time from the beginning of the season, the 1st of April, through the end of the year. The green bars represent the number of deaths or emergency department visits each day. The red line is the high temperature for the day, and the blue line is the low temperature. So we do notice that during that July heat wave, during and right after it, we had our largest numbers of deaths and ED visits, but also that many heat deaths occurred in our more moderate days and throughout the season, not just in the extremes of heat. Also, I think, if I look at the pattern here, the deaths and the ED visits are weighted more toward the early season and not so much the late season, maybe due to acclimatization or other factors, and we could talk about that. What we know about emergency department visits is this count is only the ones that were coded as due to heat-related illness. But actually, we are greatly undercoding and undercounting that. And when you look at overall ED visits throughout the country and in various studies, we know that they increase on hot days as well as hospital admissions. So that shows that not only things that we code as heat related, but other things increase during times of heat. This is really important in where I live because we are a low health state. We strain ourselves to have capacity to take care of people on a normal day. And so a prolonged heat wave that increases all sorts of ED visits and admissions is potentially very problematic for anybody presenting to the ER for care. They might not be able to get timely care that they need. So let's just look at a couple of cases. This first one came from one of our Nevada Clinicians for Climate members who's an emergency medicine resident. And he saw a typical patient that is seen a lot in the county hospital ER, male in his 60s with psychiatric disease and without reliable housing. He came in initially with a bunch of vague symptoms. He was evaluated and thought not to have anything needing admission, and he was discharged. But just 2 hours later, he was returned via the emergency medical system with a core rectal temperature of over 40 degrees centigrade, about 105 Fahrenheit, and he was unresponsive. He also had second-degree burns on both feet from pavement burns. So this presentation caused him to have to be admitted to the ICU and then to the burn unit, and he had a prolonged length of stay. Another case, which was very sad, occurred back in 2023 during another heat wave. Two locals who hiked a lot and trail ran a lot, young women, one of whom worked in one of our healthcare facilities, went out hiking or trail running in one of our state parks on a day where the temperature there reached 118 degrees. And they were later found dead. One of them was less than a quarter mile from the trailhead. I actually went out and took that picture on the left that says heat warning, hiking is not recommended, about 2 months later in September on a day that was only in the 90s. And as you could see, a bunch of people were hiking, including myself. So I think this points out that a lot of people, even if we're educated, don't always understand when we're at risk. So both of these cases illustrate heat stroke. And for the health professionals on the call, there's really a triad for diagnosing heat stroke. You have to have a high core body temperature, rectal temperature measurement over 40 degrees C. You have to have some sort of mental status impairment, either be obtunded or altered or confused, or maybe exhibiting bizarre or unusual behavior. That can be problematic because people with heat stroke have been misrecognized in the field as being psychotic or having substance use impairment, intoxication, and the heat stroke hasn't been diagnosed quickly. The third thing you have to have is an appropriate exposure history, either being in hot conditions or exertion in warm weather. Heat stroke results from a loss of the body's compensation. Our main way of compensating is sweating. And when the heat exposure overwhelms the body's ability to cool itself by sweating, the core temperature increases. This leads to a stress response mediated by cytokines that causes an inflammatory cascade. And as many people know, inflammation is bad for us in all sorts of ways. And so we get damage to multiple organs. We usually divide this into two forms. The classic form is people with risk factors. Think about an elderly person living alone in an apartment for several days during a heat wave, maybe with malfunctioning air conditioning. So often it's slower onset, maybe days of exposure. And because it can occur more during heat waves, it has a potential for epidemics. And so we know we've had epidemics of heat stroke in places like Chicago and the Pacific Northwest and Paris over the years. And this is a cause for worry in the healthcare system. The second form is that exertional form, and it was exemplified by our hikers. It can be a more rapid onset. So the classic form often presents with acute respiratory distress syndrome. The exertional form, often rhabdomyolysis or muscle tissue breakdown and organ failure. Both of these are real medical emergencies with high fatality rates. And the Society for Critical Care Medicine really reaffirmed the principles of immediate emergent care being to cool the person as quickly as possible, both in the field and in the emergency room, with cold water immersion, cold suits, cold fluids, whatever can be done. So that's the essentials of heat stroke. We have less severe heat illnesses, heat exhaustion. Many of us have seen as healthcare providers, and maybe many of us have experienced. It's characterized by a lower body temperature than heat stroke and no mental status changes. So if the person is alert and appropriate, we don't really have to worry about heat stroke. It's often able to be treated in the field just by taking the person away from the heat and wetting the clothes, using ice packs, hydration, and those sorts of things. Heat syncope means fainting due to heat. Muscle cramps, heat rash, and swelling are some other of the commonly recognized less severe types of heat illness. But I think there are a lot of things that we don't always think of as heat illness that really are, and things that I have seen throughout my primary care practice. 66-year-old man with chest pains that turns out to be a coronary problem. Middle-aged outdoor worker with diabetes, and we notice that his kidney function is decreasing over time. A young person with depression and serious consequences of depression. These are things we wouldn't necessarily think of as being heat related. But in fact, they're part of a whole category of what I like to call silent heat illnesses. They're really under-recognized. And we know from a lot of good, solid epidemiologic evidence that increased heat is correlated with lots of different cardiovascular events, including heart attacks and stroke and worsening heart failure, with chronic kidney disease, kidney stones, and urinary tract infections. Heat is both directly toxic to lungs, and also it's harmful because air pollution like ground level ozone increases in the heat, and that's very toxic to lungs. We worry about a lot of infectious diseases. That could be a whole talk of its own. But Lyme disease is increasing due to, in part, to hotter conditions, and that's important both in Colorado and northern Nevada. And I know that Rob is going to talk a lot about cognition and cognitive problems. So I'll just leave you with this picture that I think is really kind of illustrative of climate change. And what we see on the left is a map of the number of extreme heat days. So what they did was they took a baseline from the 1980s up to 2007. And then they took a period, the decade between 2008 and 2017, and they said, let's count how many days were over 90 degrees and also in the 99th percentile of heat compared to our historic baseline. And this is what they found up to and over 109 days, especially in the South and Southeast. And then we look at cardiovascular mortality during the summer months. And again, isn't it fascinating how those two maps overlap? And I think that just shows us that our heat is really affecting our health in lots of different ways. So with that, I'm going to stop sharing and turn it over to our next speaker.
Okay, thanks, Joanne. That was an awesome overview. Thanks so much. And the data was really interesting. So now we'll focus more closely on the impacts of high heat on maternal and fetal health and on children's health with Dr. Rob Byron. Dr. Byron will also discuss in greater detail impacts of heat on brain and cognitive health and mental health. Dr. Byron was planning to be joined by Dr. Lori Byron, who some of you may know, but unfortunately, she's not able to be with us this evening. She had an unexpected request to speak at a special youth event and decided that it was very important that she do that, and we agreed. So fortunately, Dr. Rob Byron is on top of both his and Lori's topics. He practices internal medicine in Montana and is on the executive committee of the Medical Society Consortium on Climate and Health. Rob, please take it away.
Okay, thank you, Susan, and thank you for the opportunity to be here. So my topic tonight is too hot to fill in the blank with whatever you think appropriate, and I'll fill it in a little bit later. But before we start, we'd just like to remind everybody that climate change doesn't cause the problems, most of them. With the possible exception of sea level rise, climate change only worsens what already exists. I mean, we have infectious diseases, we have floods, we have storms, and we certainly have had heat waves, but they are dramatically worse under the umbrella of climate change. And since we're talking about heat, I want to go back to the basics and hopefully don't induce too many bad flashbacks for people by bringing up a bell curve. Um, but just a reminder that this is just a bell curve or a Gaussian distribution, which is typical for any type of measurements, including temperature. And most of the temperatures, if we have an average temperature, most of the measurements will be around that temperature, but you will still have some that are outliers or all the way to the left, really cold, or all the way to the right, or really hot. The important consideration here with climate change and particularly with heat is if we move that average temperature up even a small amount, the whole curve shifts. And what we see on the left is, well, there is less extreme cold weather, probably not enough to be clinically significant. But on the right, what we see is not only are temperatures hotter, but a dramatic increase of more hot weather with just a small shift in that curve. And that's exactly what we're seeing and exactly what Joanne just discussed. So take everything Joanne said about the way heat affects us, apply it to children, and multiply it several times, because that's about what it boils down to. And there's some reasons for that. First of all, children are more susceptible to all environmental factors, including heat. They have a higher surface area to body mass ratio, so they have increased absorption of heat. Children need more food and water per kilogram than adults. They have higher respiratory rates, different absorption and metabolism, and their blood-brain barrier is more permeable. A different way of thinking about that is in terms of exposure, and I'll bring this home dramatically in a couple slides beyond, but basically, if they get impacted as a child or even in utero, they not only have a longer time for those impacts to manifest over their lifetime, but they're also at risk for more exposures. Their behavior, as they spend more time outside than most adults, except for a lot of outside workers, and certainly their hobbies and high-risk activities, especially teenagers who are subject to a lot more peer pressure. And then also their particular windows of vulnerability. When the blood-brain barrier isn't fully formed or when they get exposed in utero. And then another risk factor is their dependency on others. So what do we know or what do we found? This is a study from 2024. It's a scoping review where they looked at a lot of the literature that was out there. They started with about 1,700 studies, ended up with about 113 that were included, and showed that during extreme heat or heat waves, there were adverse birth outcomes, increased ED visits, more asthma exacerbations, certainly more heat illnesses, and as Joanne said, impaired school performance. Now think about that and think about a lot of the schools that we have nationwide that don't have good air conditioning or good ventilation. And being there during some of these heat waves, either late spring or going up into the fall. And this is one study that I included because it is so dramatic. One, I have to point out, it is a single study. So it needs to be followed up on. But this is from the Netherlands, and what they showed was that they took a group of 2,700 children and looked at their exposure to extreme temperatures, cold as well as heat, either during in utero, during infancy or toddlerhood. And of those 2,700 children had MRIs later in life during the pre-adolescent years. And what they showed was any exposure to extreme temperatures, heat or cold, manifested as MRI changes on pre-adolescents 10, 12, 15 years later. They saw decreased myelination. Now, for those of you that aren't physicians, myelin is the insulin, the sheath that goes around our nerves. Think of the insulation going around wires. When the insulation breakdowns, the wires do not work correctly and all kinds of bad things happen. Now, this was purely an anatomical study, but if this is duplicated, that just gives you an idea of the impact of exposure to extreme temperatures. Also, keep in mind that, as we talked about before, we're seeing more hot weather, less cold weather. So we're going to see more of the latter. let's shift and look at pregnant women, and just going to look at a single study because this is one of the seminal studies done to look at the heat impacts on birth outcomes from Bakar et al. In 2020. And what they showed, they looked at a lot of studies and showed that just with heat, now this is separate from air pollution, understanding that air pollution gets worse as temperatures go up, but this was an independent variable here, that just with heat, there's increases in preterm birth, low birth weight, and stillbirth. And look in that lower right-hand corner at that one box that's included. Stillbirth increased about 6% if the mother was exposed to heat during the week before delivery. And think how often that happens in many of our settings in families that don't have access to air conditioning or cooling centers, and just translate that into the numbers of children that could impact. This next, which I'm not going to spend a lot of time on, but I provided it for those, this discusses some of the mechanisms from that same study of why exposure to heat may impact a pregnancy at different impacts, or I'm sorry, different parts of the pregnancy. Let's move on to one of the less recognized and one of the bigger elephants in the room when it comes to climate change, and that's mental health. When we talk about heat alone, without bringing in floods, storms, and all of that, heat alone, we see worsening of sleep and insomnia, more aggression and interpersonal violence, more suicide, more mood disorders, and decreased cognition. We don't think as well. And I'll just focus on that briefly because there's a very good study that took two groups of college students, one in a air-conditioned building and one in a non-air conditioned building, gave them some testing, and the ones in the air-conditioned building performed better. They switched them, did it again and again. Now the group that was in the air conditioning building performed better with measurable differences. And think about that. That was over just a few hours, not over days, like we're seeing with some of our heat waves. Also want to point out that for many of these mental health aspects, they are worse in children. And these slides, by the way, are courtesy of Dr. Robin Cooper from the Climate Psychiatry Alliance, and they were so good, she allowed me to use them, and I just kept them. This one I included because it is so dramatic, and just look at the visual. Don't worry about the mechanisms of heat impact on brain. Just think of that visual, that's what's happening for a variety of reasons. Increased inflammation, cellular changes, membranal changes, weakening the blood-brain barrier are thought to be some of the mechanisms through this. But think of a brain on fire as it would be in the heat that we're seeing. And then lastly, a couple of studies. This is a study from 2019. This was, they interviewed 10,000 youth in 10 different nations, including the United States. Now, this is not heat specific, but it's so important that I thought it worth sharing. And that is, what they found is that of these youth aged 16 to 25, 60% of them were worried. 50% said 75% said the future is frightening. 50% said humanity is doomed. And on of just how much impact climate change is having on our youth. And then the last slide is, this is how I would fill in the question mark. Too hot to breed or too hot to procreate. This is from New York Times in 2020, and studies showed that with all that's going on, much of it related, that was pandemic, of course, but it's also climate change and the political strife, that so many of our young adults and young women and young men are so concerned that they question being able to or wanting to bring children into the world. That is speaks such volume that I think we need to heed that. And then I'll end. This is just a resource. In 2023, there's a very good report on mental change or mental health and our changing climate in children and youth from Eco America that I highly recommend. And with that, I will turn it over to Logan.
Okay, thanks, Rob. That was really an excellent deeper dive into some special areas of concern. So now we're pleased to have Dr. Logan Harper speak on building resilience to heat at both personal and community levels. Dr. Harper is a family medicine physician and climate and health policy fellow at the University of Colorado, and he is also affiliated with Hawk. Logan, you have the floor.
All right. Thank you, Susan. And thank you to Joanne and Rob for laying the groundwork here. I love to be the guy who gets to talk about, what we do about these seemingly intractable problems. So hopefully we can end on a little bit of a hopeful note here. As just a brief outline of what I'll be discussing, first I'm going to define the term resilience. I know it can sound a little bit jargony, and then we'll talk about how it applies to individuals versus communities. Next, we'll kind of revisit how do we determine who's vulnerable and how do we let that information guide our heat action plans, the policies that we're going to put in place both individually and as communities to help keep people safe. Then we'll talk about a little bit of a more specific healthcare focus, talking about the impact of heat on health systems and what we do about it. And then focus on the community resilience more broadly. And we'll end with a call to action, which is a letter to the National Governors Association. So resilience really is just the ability to cope with shocks and recover from their impacts. This is a term that gets used a ton in climate literature and climate discussions. But when it comes to extreme heat specifically, there's three parts I think we need to think about. One is just how do we cope with heat? And that can be very simple personal actions like, knowing where you can go to escape a hot house, stocking your fridge with cold drinks, that sort of thing. Adaptation is more fundamental change in our environment. So planting more trees in our neighborhoods, building homes with better insulation so we don't have to run the AC as much, or we can stay cool even if we can't afford AC, that sort of thing. And then transformation are major shifts in the fabric of our society. So that can be things like, agricultural industries that used to be able to thrive in a location no longer can because of heat. And so we have to shift, where we get our economic livelihood from in that region. In some cases, people are actually moving their entire communities because of climate change. We're not seeing that a ton from heat yet. We are seeing it from hurricanes, but the trajectory of worsening heat waves suggests that that level of transformation might be necessary, over the next century. For individual resilience, the first thing we need to focus on is identifying who is most vulnerable. And Rob and Joanne have done a great job of going over that. I just want to propose that we think about this in two separate categories. So there's the physical vulnerability that you have when you carry a chronic health condition or your body isn't able to adapt to extreme heat. And that can include folks who are pregnant, really young people, really old people, people with chronic conditions, and people on a lot of different medications. And then there's the behavioral and socioeconomic category of vulnerability. And that's folks who can't afford to run their AC, can't afford to move out of a really hot neighborhood, have to do a difficult manual labor job outside in the heat, that sort of thing. I wanted to take a second and focus on medications because I think they're an under-recognized risk factor for getting sick from heat. There are a ton of medicines that we prescribe throughout all the different fields of medicine that are necessary to treat chronic conditions, but can really increase your risk of developing heat illness. And some examples are, pretty much anything that interacts with the brain can impair your brain's ability to regulate your body's own temperature. And that includes things like some antidepressants, stimulants like Adderall used to treat ADHD, antipsychotics. So, that's a broad category of medications, but they all increase your risk. Anything that can reduce the amount that you sweat also can increase risk. An example of that that's very common is Benadryl. For blood pressure and heart medications, a lot of them are designed to reduce how hard your heart works to prevent it from getting overly stressed. But the primary way that the human body adapts to heat is by taking all the blood from our core and shunting it to the periphery, just meaning to our skin. And your heart has to pump a lot harder to make that happen. And if it can't, because it's limited by medications that you're taking, you're much more likely to overheat. And the last category is dehydration. We take water pills to get fluid off our bodies, things like that. Those things will obviously make you more prone to dehydration and electrolyte abnormalities that can lead to serious heat illness. So now that we sort of talked about how do we identify who's vulnerable in terms of a demographic pattern, we got to think about understanding our own personal risk in terms of where we live. And not everybody has access to the sort of maps that Joanne showed that detail the highest risk neighborhoods in their city. So I wanted to just share this tool with everyone. It's called the CDC Heat Risk Forecast. You can scan that QR code to get a link to the webpage. This is a screenshot from last week. We had a particularly hot weekend here in Denver, as across most of the country. And you can see that it forecasted major heat risk for 3 of those 5 days. If you don't know what to do about that, it has a ton of information, both for healthcare professionals and for the lay public, to understand how to limit your own heat risk, how to stay cool, stay safe, how to recognize heat illness, and what actions to take if you start noticing some of those symptoms. Another option is this app that you can get on your phone. It's made by the Occupational Safety and Health Administration. And it's similar to the heat risk forecast from CDC, but maybe has a little bit less information. It's nice though, because then it's right in your pocket. You can even set it to ping you with alerts if there's going to be a high heat risk day coming up. So what do we do to stay safe on an individual level? The most important thing is having a plan, right? If we're caught off guard, caught flat-footed in the middle of a heat wave when we're starting to have symptoms, oftentimes that's too late to take effective action to stay safe. So anticipating in advance what risk factors you have and what you need to do about it is really, really important. That can include things like how are you going to keep your house cool? Oftentimes that starts the night before the hot day so that you can cool it down as much as possible by keeping your windows open at night. It can also include things like if you have a power outage and you can't run your air conditioner, or maybe you don't have air conditioning at all, but you expect you might need it over the next few days. What's your backup plan if your house gets too hot? Where are you going to go to get the help that you need? And then keeping those vulnerability factors that we just talked about in mind. Who needs a checkup? Who needs to be called? Who needs to have somebody stop by and knock on their door and make sure they're okay? Think about your loved ones, your neighbors, your family members. One phone call can go a long ways because most people don't understand the health risks that come with heat exposure. And if you can clue them into that, you could potentially save their life. Longer term preparation includes things like just, retrofitting your house, buying window shades, purchasing fans ahead of time, AC units, improving the insulation. And all of that stuff costs a lot of money, is not accessible to, the population at large necessarily. So I want to acknowledge that. But if you have the means to think about these sort of upfront investments, not only will you stay more safe from heat waves, you're actually going to save money and recoup your investment over time because your electricity bills during hot weather will be so much lower. One other thing to note, fans actually are not evidence-based to protect you when the temperature is over 95 degrees. So fans help your sweat evaporate more effectively. But when you live in Colorado or most of the Mountain West, your sweat already evaporates really easily because it's so hot and dry in the summer. And so the fans might just dehydrate you more. And there's some concern that they can increase the risk of heat illness over that temperature threshold. This is an example of a heat action plan that you can make with your doctor to kind of like go through that bullet point list that I just presented. It's really, really basic and high level, right? But it has most of the information that you need to stay safe, and it's applicable. Like almost anybody can understand this, even if you don't necessarily read English. You can sort of understand the implications just based on the graphics. It also has a link to the CDC heat risk dashboard that I mentioned. And I also really like that it mentions air quality. So air quality gets much worse on hot weather days for a variety of reasons. But if we're thinking about trying to open our windows to cool off our house, we need to be aware of what kind of toxic air are we letting in, and is that really a good idea? Because a lot of the chronic health conditions that can become worse due to heat exposure are also exacerbated by bad air quality, and we want to avoid having that double whammy there. We've already talked about recognizing heat illness, but I just wanted to highlight personal resilience is very dependent on understanding what level of heat illness you're experiencing. Where are you at on the spectrum from heat cramps to heat stroke, and what sort of action do you need to take to stay safe? Next, we'll move on to a more of a healthcare focus. So as Joanne already presented, we have a ton of emergency department visits, really, really high burden on our healthcare system during heat waves. So this chart on the left is from the heat wave that hit the Pacific Northwest in 2021. And it got up to about 116 degrees in Portland, Oregon. It's a traditionally cool climate where a lot of people don't have AC. And you can see the gigantic spike in emergency department visits compared to what's normal in 2019, which was the year before. So keeping in mind that that's pre-COVID and kind of projected to be, this is our normal summer, surge of heat-related hospital visits. It's a tiny little bump. And then you have a severe climate-driven heat wave two years later, and you get over 1,000 visits over just the course of a couple days. Just this week, there was a hospital in Brooklyn, New York, that had to basically their HVAC system is failing, and so they're having to put window AC units in patient rooms. Everybody's sweltering in the heat. People are voluntarily leaving the hospital. So this is just an example of how we need our health systems to be prepared to be the island in the storm that people expect them to be during any kind of natural disaster. And that's really what extreme heat is. In terms of how we prepare our workforce, I just want to give a shout out to my home program, which is the University of Colorado Climate and Health Program. And we run a diploma in climate medicine, which educates all sorts of different healthcare providers on how to participate in a climate smart future of healthcare. The last section here is just talking about community heat resilience. There's a million different ways that we can reform and reshape our communities to keep people more safe from extreme heat. And we have to be really intentional about how we do that, or else we're going to waste a lot of time and resources without helping people very much. So the first step in promoting community heat resilience is understanding who's vulnerable, right? This goes back to individual heat resilience. This is a key point across all management of heat-related illness. We got to understand who's at risk. And these heat vulnerability assessments, this is similar to what Joanne showed in her talk, but this is for Denver. And it's not just highlighting neighborhoods in red that get hot. It's highlighting neighborhoods that get disproportionately hot compared to the rest of the city, but also have populations who are at increased risk. So lower income, lower rates of speaking English, that sort of thing. So once we've identified who's at risk, what neighborhoods, we need to engage with those communities to figure out which of the many solutions we have at our fingertips that they actually want. Because if we don't, then like I said, we risk wasting our time and money. New York City had this experience a few years ago. They were experiencing more heat waves than they had in the past. And so they made a decision to open cooling centers in vulnerable communities. And they'd have like an entire high school gymnasium that was air conditioned and open to the public. And they'd have 3 or 4 people show up, in a neighborhood that has tens of thousands. So that's not the kind of return on investment you want to make if you're local policymaker. So how do we make sure that we get a better return on investment? We have to engage with the communities. We have to do a community needs assessment, talk to the people who are actually at risk and figure out what they need to stay safe, and then help them access those resources. And there's, short-term resources versus long-term resources. They're both very important. Short-term resources can be stood up this summer, and those are things like cooling centers, giving people cold drinks, public awareness campaigns. Long-term solutions are more about how do we reshape our built environment, our buildings, our parks, our roadways, our schools, to keep people safe, and keep the city from heating up so much. I wanted to make a special note about early warning systems. So these are, used across the board for natural disasters. And again, I want you to think of extreme heat waves as a natural disaster because they kill more people than hurricanes, floods, and tornadoes combined in this country. The way that we communicate with the public in advance of these things is super important. And there are a lot of studies showing that a good early warning system can save thousands of lives from an extreme heat wave. And there are a ton of options for how we communicate: billboards, social media, radio ads, flyers, door knocking campaigns. All of these things are viable options, but again, we got to work with the community to figure out what actually resonates with them and what messages will get through, because some folks are not necessarily going to be paying attention to the weather. They might not be able to read the billboards that you put up on the highway, that sort of thing. I wanted to highlight an example of a city that's doing a really good job with this. So Athens is the hottest major city in all of Europe. And what they've done is create a heat health forecast where they grade heat waves, either moderate, severe, or extreme. And these gradings kind of trigger a citywide response. And the more severe the heat wave, the more resources they make available to respond to the issue. They also name their heat waves, just like we name our hurricanes. And that really helps the public understand the severity of the problem. It improves officials' abilities to communicate with the public and get people to pay attention and take these things seriously. And so that's had a major positive impact on their ability to manage heat illness in a really, really hot city. Some other positive examples: in Medellin in Colombia, they built 36 different green corridors, which reduced the temperature of the surrounding area by about 4 degrees Celsius. So maybe 7 degrees Fahrenheit. That's significant. It can make a major difference between somebody getting sick and not getting sick from extreme heat. Seoul did a similar thing with waterways. Paris is using water from the Seine to water green areas and in hot districts in their city, and also creating public water features people can use to cool off. And Melbourne's doing a similar project where they're trying to integrate as much natural space and forests throughout their urban environment. This is an example. This is sort of a complicated figure, but bear with me here. This is an example of the benefits that Medellin experienced as a result of their Green Corridors initiative. So just ignore the bottom part of the figure here. We're just going to focus on the top half. And what that shows is all of the benefits that they experience from these corridors. So on average, throughout the entire city of Medellin, they decreased heat by 2.7 degrees. Remember, it was 4 degrees near the corridors, but for the entire city, the average decrease was 2.7. And what that translates to is 31 fewer days every year that meet the threshold for extreme heat. And this reduction in exposure to extreme heat translates to 116 fewer cardiovascular related deaths every year and $96 million in savings. So I'm sure it was an expensive upfront investment, but they're recouping that investment and saving lives in the process. So obviously, we can't do this as individual healthcare providers. We can't do this as individual members of the public. We need policy leadership to step in and help us address this, existential challenge. And so that's why this call to action is for folks to sign on to a letter calling for states to improve heat resilience at the state government level. So the Alliance for Heat Resilience and Health is sending this to the National Governors Association, which every state governor in the US is a member of. And they're doing it in July, calling for 4 key policy initiatives. One is to launch an assessment to understand each state's risks around heat. The second is to designate a heat czar, somebody in state government who can take on a leadership role and make sure everything is cohesively moving in the right direction. Number 3 is considering extreme heat as a real state of emergency, which allows the government to mobilize the resources needed to combat the problem. And then lastly, we need financing in the long term to build the kind of environment and society that is resilient to heat that I've laid out here. And so there needs to be long-term strategies to make that financing happen. Anybody who's part of any formal organization can sign on to this letter. You don't have to be a health organization. You don't have to be a climate organization. If you feel like you can convince your board or your leadership to sign on to it, please scan the QR code and it'll bring you to a sign-on page that you can share with your organization. With that, I'll hand it back to Susan. Thank you.
Okay. Great. Well, thank you so much, Logan. That was really a great discussion. And let me just close this out. So Kate Jennings is going to be leading our Q&A session here. And Kate, do we have questions for the speakers?
We sure do. Thank you so much, and thank you to all 3 of you for your talk. I think the first question really can go to all 3, and I'll be interested to hear your input. The first question asks, is there a documented correlation between deaths and heat illness susceptibility for disadvantaged communities with the cultural and societal barriers of limited access to appropriate levels of health care? And if so, how can this barrier be overcome from the perspective of a health professional?
Well, I'll speak to that just a little bit. Just from our perspective in Las Vegas, I think it's really complex. In that group of maps that I showed that showed the highest heat vulnerable areas, you could overlay another map that shows the availability of healthcare or the number of health facilities. And you would find out that because those hot areas are low income areas, they're also underserved in terms of healthcare. And I know about this having worked in one of those heat islands in a primary care clinic for a number of years. So definitely as health professionals thinking about, training ourselves and being able to work in those underserved areas is one way that we can respond. On the other hand, it's not just a straight line. For example, the Hispanic population in my city probably is protected in part because our Latino communities tend to be very family oriented and we do not have a lot of isolated people. We have a lot of older parents living with younger generations or close by where they can get checked on. So there's not like a straight line between being a member of a minority population or a frontline community and necessarily always having increased heat risk.
So, and I'll jump in on what we can do about it. And I think there's a couple different levels of that. And one is certainly, as Joanne addressed, working in those communities is one. But secondly is even if we don't work in those communities, working within our organization, whether it's a clinic, a hospital, a healthcare system, to start to address some of those issues because all of those serve patients from those communities is a second one. And probably the last one is probably the most important, and that is we have to expand our advocacy outside of the exam room, whether it's at the local level with local elected officials or signing on to the letter from the National Governors Association, things like that. We are, as healthcare professionals, trusted messengers, and we need to take advantage of that and speak up.
Yeah, I absolutely second that. And I also wanted to speak to what we do within our own health systems. Right now, healthcare providers, especially in primary care, have no time to either learn about this or talk about it with their patients because they already are struggling to get to all the super crucial stuff that they can't talk about in a 20-minute visit. So we need to build in systems level solutions where we're getting reimbursed as healthcare providers to talk about it, or we're paying other staff like social workers and case managers to reach out to our higher risk patients and counsel them on what they need to know. And then speaking to the like, how do we address the most vulnerable communities? I'll just go back to the community needs assessment component. We need to talk to them, right? Like Joanne was saying, you may have a Hispanic community that lives in a similarly hot neighborhood and has a similar socioeconomic status to an African American community, but their heat risk is, or the impacts of heat on their health can be totally different. And if we don't talk to them about why, the solutions we design on their behalf are going to miss the mark.
Excellent. Thank you all for that. The next question is about, and Dr. Leovy, I think you sort of spoke to this one better. Is there insight into why there are higher levels of heat-related illness in substance abusers? Does substance abuse degrade organ systems, which make them more prone to heat, or are there other factors at play?
I think there are factors. Well, it's an interesting question because, for one thing, we think that there are things with psychotic illness where the illness itself might increase a body's tendency to have heat illness. But many substances, for example, I said amphetamines or methamphetamine is a big problem. And it probably is a problem because it increases the rate of metabolism. Heat also increases the rate of metabolism. So somebody's heart and metabolism is going as fast as it can, generating more internal body heat, and it just becomes overwhelming. Methamphetamine and stimulants also change the pattern of circulation so that certain organs might not be getting as much circulation and might be more vulnerable to damage. So there are a variety of factors with the different substances that can impair the person's ability to respond physiologically, as well as, of course, substance use can alter a person's ability to take care of themselves and protect themselves from heat exposure.
Excellent. Thank you for that. The next question has to sort of do with U.S. cities and their response. So, do any of the panelists have any idea of how many U.S. cities have a heat action plan? And more importantly, what advice do you give residents of small towns, let's say under 200,000, where no action plan exists to help encourage elected officials to launch such plans?
I could speak to at least the first part. I know that there are many US cities with the heat action plan, including Phoenix, Miami, Denver, LA, Las Vegas, the cities that you would expect largely have them. And more of them are rolling out every year. I don't know the exact number, but people are waking up and paying attention. And I think if you're trying to motivate your smaller town or small city leadership to do the same, highlighting those examples is a good place to start. And I think that when folks realize the impact that extreme heat has on both health and lives and the economy, it's easier to think about it like a extreme weather event, like a natural disaster on par with a hurricane. And that's kind of off the radar for most people, including policymakers, scientists, physicians. And so just bringing a little bit of data to the table that supports that can help make your case.
And I'll also add to that, I agree with everything Logan said, but all of these start with one person. But one person can't do it alone. So partnering with organizations, and it doesn't have to be a climate or a health organization, certainly housing, environmental justice, mental health organizations, nonprofits are all very aware of these issues and can help to start a movement with any given area. Specifically, just like Hawk, there are climate clinician groups in now about 28 or 29 states that if you have one in your state, reach out to them because this is the very kind of work that we want to help with.
I just want to add one quick thing, which is that there are already resources out there. So your small town doesn't have to reinvent the wheel. Susan, can we send out a list of resources for folks afterwards or?
Right. We were planning to do that. Yeah.
Okay. I'll make sure that I've included that in in the list. There's like a whole toolkit for cities in terms of how to build heat resilience.
Correct. And shouldn't most of those plans for cities be publicly available? Correct, Logan?
I think they all are, yeah.
A great place to look is Maricopa County, which is Phoenix. We're trying to model some of our responses on them. So just adopting a few things that they've done can make a big difference.
Well, thank you so much. We are at the top of the hour, so I want to be mindful of everyone's time. So Susan, I will hand it off to you.
Okay, great. Well, thanks so much, Kate, and thanks to our speakers, Dr. Leobi, Dr. Byron, and Dr. Harper, and to all of you who have made time in your day to attend. We really appreciate it. Also, some great questions. Thanks to Citizens Climate Lobby and its members and leaders who helped with and supported this webinar, and to Healthy Air and Water Colorado, and especially Alex Boyan and Elizabeth Batiste, as well as its partner organizations and physicians. As Logan sort of asked earlier, we'll follow up by email with everyone who registered for the event with a link to the recording of the presentation and also some resources for folks. We encourage you to check out the CU Anschutz School of Medicine Climate Diploma and to sign on your organization to the Alliance for Heat Resilience and Health Letter. And so details about that will be in the follow-up email. And also, if you're interested in becoming involved in climate advocacy with Citizens Climate Lobby, we'll put contact information in the follow-up email on that too. So thanks again, everyone. And we'll close out for now and have a great evening. Take care.
Thanks, everybody. Stay safe.
Thank you.